Hello friends, uh, welcome. I am Dr. Ajay Yadav and today we are going to discuss FMG MCI recall questions of August 2020 anesthesia questions. Actually this time I found that questions were little difficult from the previous years. Although few questions are more or less clinical but still they are little difficult. So without wasting any time, let's start away, proceed to the questions. So, question number one: a 30-year-old car driver was involved in an accident. He is brought to emergency room with complaints of breathlessness. On physical examination, vitals are pulse rate is 110, means little tachycardic. BP 90/60 means hypotensive, and temperature is 37 normal. Extensive bruising is noticed on the right side of the chest. Air entry was significantly diminished. An urgent bedside X-ray test was performed. What is the best management for this patient? Thoracotomy, thoracostomy, elective intubation, and positive pressure ventilation, fluid resuscitation. Actually, for exact management, definitely I will need some more information. Like very important, what was my finding on examination, like auscultation, percussion, that we will also do. And another very important information I would like to get in this patient is what is the oxygen saturation of the patient. And moreover, to confirm my diagnosis, I will wait for this X-ray report also to see urgent. X-ray report is immediate. You need not wait. There is display nowadays in all these X-ray machines. Instantly you can see on the monitor. So that all information I'll be needing to reach a complete diagnosis. However, whatever the information available in the question, we have to go by that only. So let's go only by that information. Complaining of breathlessness and physical examination, tachycardia and hypotension, bruising on the right side of the chest, and air entry decreased. So this most probably, so your tentative diagnosis can be pneumothorax, pneumothorax, or hemopneumothorax. So this hemopneumothorax or pneumothorax alone or hemothorax will lead to hypotension. There can be lung contusion. So there will be tachycardia. Since patient is breathless, so obviously the most important immediate thing is we have to drain whatever in the pleural cavity. And I told you with immediate X-ray, we will be able to see whether there is a pneumothorax or hemothorax. But unfortunately, sometimes air present on the anterior side may not be seen in X-ray chest. So we have to go by clinical examination. And on clinical examination, definitely decrease air entry already has been mentioned. I would like to do percussion. And percussions, if you find resonant tone, that means it confirms pneumothorax. And management of pneumothorax or hemothorax or hemopneumothorax is immediate placement of chest tube, ICD. As a life-saving measure, you can put a needle also. Previously, we were putting in the second intercostal space. Nowadays, they say that in lying down position, supine position, more air or collection can be drained best through fourth or fifth intercostal space. So immediately you can put a chest tube, thoracostomy tube in fourth or fifth intercostal space, mid uh, axillary line, or some people put it in anterior axillary line also. And best is if you can do is it under real time ultrasound, so that can also confirm. So that should be done. So for this patient, on the information available with me, my diagnosis will be pneumothorax and or hemothorax, and the management is immediately placement of chest tube, thoracostomy. Elective intubation and positive pressure ventilation can actually worsen. You know that positive pressure ventilation positive pressure ventilation can increase this pneumothorax to an extent to cause tension pneumothorax and collapse. So even if you are intubating this patient, I'll be intubating this patient only after putting the chest tube, even if you have planned to intubation. So immediate management with chest tube, and if patient is really desaturated, we may need to intubate, but only after placing the chest tube. Yes, fluid resuscitation will be the part alongside, but not as a life-saving measure. It will also be a part along with the chest tube. Okay, just let me check whether recording is going proper or not. Sometimes the recording goes off. No, that's going fine. Okay. Identify the following instruments. LMA, that is laryngeal mask airway pro seal, tight seal, high seal, classical LMA. If you ask me, most important equipment which definitely is expected, and every exam or every alternate exam you see a question is on laryngeal mask airway, LMA, because LMA actually has revolutionized the anesthesia practice in say last decade or so. So LMA, I like to avail this opportunity to explain about this LMA, and then we'll come back to this LMA question. Uh, so this is actually a classical LMA. Classical LMA, and how does it work? You can see this is a tube and this is a cuff. So it is placed blindly in the oral cavity so that this cuff part lies in oropharynx. When you inflate this cuff with a large volume of air, like this. So when you inflate with large volume of air, this cuff will seal the oropharynx from all sides. Now if you ventilate through this uh, tube, you can see these holes. So through this tube, through these holes, air will have no option to go anywhere. So automatically it will enter the larynx. And important to deflate. So I'll just go to the classical LMA because that's really very important. See, this is the classical LMA which I show you. So if you ventilate through this tube, through this holes, air has no option but to go to larynx. So basically, when LMA was manufactured, synthesized, is basically used for emergency airway for failed intubation. If you're not able to intubate the patient, as an alternative, you can place laryngeal mask airway. However, over the years when we started to use LMA, we found it to be so effective method that nowadays we are using it routinely for you can say elective surgeries. Previously we are using only for short duration surgeries, but now we are using for moderate duration as well as long duration also in select cases. So now it is used as an elective method as an alternative to intubation. So the basic advantage is that you can avoid all complications of intubation. Intubations carries plethora of complications, so they can be avoided. Then it is easy to insert. For you don't need laryngoscope, no laryngoscope required, and even you don't use muscle accent, you can still place without putting muscle accent. For intubation you need laryngoscope as well as muscle accent and expertise also, and can be placed in any position of neck. Means very useful for cervical spine fracture patients. But nothing in the world has only advantages. There are disadvantages also. One of the big disadvantage of LMA is that this LMA rests over the esophagus. It is not blocking the esophagus. So air can still leak from sides and can enter the stomach, increasing the intragastric pressure, increasing the risk of aspiration. So risk of aspiration, increased risk of aspiration is the, you can say, biggest disadvantage or limitation of LMA. And another problem is if you are uh, you are clearly seeing that air is getting leaked and patient's stomach is getting distended, still you cannot deflate, because from where you will pass your suction catheter Rayleigh tube, because the cuff of LMA has occupied the oropharynx, so you'll not be able to deflate the stomach also. But this problem is not seen nowadays, because nowadays we are actually only using second generation LMA, and the classical example of second generation LMA is ProSeal. So this is ProSeal. So what the difference? You can see that there is a separate port for stomach decompression. You can see you can pass your suction tube or Rayleigh tube through this conduit, and then through this hole it will enter the esophagus, so you can decompress the stomach. So it is classical ProSeal. Then one more very frequently used in India is iGel. The only difference is that this cuff, which is filled with air, is replaced with a pre-filled gel. So all air related complications like stomach, this air can get, this cuff can get deflated. If this cuff get deflated, you know that then it can rotate, it can even touch the larynx, inducing laryngospasm. It itself can cause airway obstruction. So, or sometimes when you are taking this out, the patient may bite this cuff, leading to injury to the cuff, damaging the cuff. So all these problems can be avoided because of this iGel. And since it is a second generation LMA, so you can see that there is an option where you can pass your suction catheter Rayleigh tube through this, and then through this hole it will enter the esophagus. Then they have different modifications of this second generation LMA like BASCA, where there are three ports, one port separate for suction, one for ventilation, and then there is a separate port for you can say suction. I told you one port, so you can keep your tube from this. There is two cuffs also. So many different modifications are there. Then we have one more LMA Supreme. Additional advantage is that there is a bite block, so that patient will not be, if patient is not fully you can say under anesthesia, is light anesthesia, so he or she can bite the tube, damage the tube. So bite block is there, so that patient is not able to even bite this tube. Now I think we can go through your question, and now you can easily identify that this is a LMA ProSeal. You can see there is a separate suction port from where you can pass your Rayleigh tube or suction catheter, and through this hole it will enter the esophagus, and this port is used for ventilation. So this is LMA ProSeal, second generation LMA. Okay, now let me check about the status of recording. Yeah, okay, that's going fine. Identify the following tube: univalent tube, single endotracheal tube, double lumen endotracheal tube, Rayleigh tube. Even if you don't know anything, if you just apply the common sense, you can easily attempt this question. It cannot be single lumen endotracheal tube, because, and you can see there are two ports for ventilation. Two ports for ventilation. So obviously it is a double lumen endotracheal tube. So double lumen endotracheal tube. So What actually are the use and double lumen? You can see two separate cuffs to inflate these cuffs. Two cuffs you can see. So this is actually a tracheal cuff, and this is endobronchial cuff or bronchial cuff you can say. So where actually this double lumen tube is used? So this is a conventional endotracheal tube, you know. So this is a single lumen or conventional endotracheal tube which is used for intubation and ventilation, and there is a cuff system which inflate this cuff, and this cuff is used to prevent aspiration. So this is used for normal ventilation. Although honestly speaking, asking about double lumen tube from you is little, I say over expectation, but since they've asked, so really we cannot help it. So these are the double lumen tubes. The same type of tube that was the diagram, then this is the original diagram. So when you remove this cup, these two ports will open. And there are two cuffs I told you. Now this double lumen tube actually where it is used, as the name suggests, means it is used for selectively ventilating one lung. And where we want to selectively ventilate one lung, when you have to separate two lungs. Now the common indication may be lung separation. And why you want to separate lungs? So that you can prevent spillage of infected content from one lung into the other. This infected content may be pus or maybe blood or maybe malignant cells. Like for example, if you are draining left lung abscess, so you don't want that this pus should enter the right lung, or there is a hemorrhage, you don't want this blood from left lung to enter the right lung, or you are doing bronchopleural lavage for say malignant cell, so you not like that this unilateral malignancy to become bilateral. So what we will do, we will place our this lumen, bronchial lumen, into right lung, inflate the cuff so that this pus, blood or malignant cells does not enter the right lung, and you can ventilate the patient through right lung. Another indication is thoracic surgeries. Thoracic surgeries. So thoracic surgeries, sometimes it is very difficult for the surgeon to operate on a moving lung. So they will ask us to collapse that side so that they can operate on the non-moving or non-ventilated lung. But this one lung ventilation or double lumen tube is not devoid of complications. The patient during one lung ventilation is very prone for hypoxia, mainly because of two reasons. One can be malposition. Malpositions mean wrongly placed. Say your left lung is unhealthy and you have decided to ventilate the patient only through right lung. So, but by mistake your tube slips into left lung. Then you are ventilating unhealthy lung while healthy lung is collapsed. So that can cause significant hypoxia. So therefore we have to confirm the position of this double lumen tube by bronchoscopy. You all know that to confirm the position of endotracheal tube, the best is capnography, measurement of end-tidal carbon dioxide. But end-tidal carbon dioxide cannot tell whether this CO2 is coming from left lung or right lung. So for that you need bronchoscopy. And so confirmation of position of this double lumen is done by bronchoscopy. Then second reason for hypoxia is weak mismatch. Weak mismatch. Why mucus mismatch? Obviously, you are ventilating only one lung. Second lung is collapsed. Means that is only perfused, not ventilated. And the lung or the area of the lung which is perfused, not ventilated, constitutes shunt. So you have made one lung to become shunt. So significantly increasing the ventilation perfusion mismatch. And because of the mandatory use of bronchoscopy, actually, nowadays the incidence of malposition has been reduced so and so that you can say that nowadays ventilation perfusion mismatch is rather the more important cause of hypoxia. Okay, so let's now go back to your question. So this is, now you can clearly see that's a double lumen endotracheal tube. So that's why actually I said that nowadays in this year the questions difficulty level was little high. Okay, let me check the recording. Okay, fine, that's going well. Question number 4. A lady was taken for cesarean section operation. The duration of surgery was more than anticipated and the patient led jump into post-operative hyperventilation. Which of the following could be the reason for that? High spine anesthesia, malingering, hypoxic encephalopathy, cranial nerve palsy. Honestly speaking, since it is a recall question, so I got question in this manner only, but this question is not exactly complete. There is some very important vital information missing from this question because that's not a complete question. But anyway, again, uh, we have to discuss whatever available with us. So let's go by this. A lady was taken for cesarean section operation. Now, most probably, the patient was given spinal. Actually, for cesarean, if absolutely necessary, then only we give general anesthesia. Otherwise, cesarean sections are done in spinal anesthesia, and the reason is because gynae patients, means obstetric patients, pregnant patients, are very vulnerable for aspiration. The risk of aspiration is 8 times more than a normal patient. So patient is so vulnerable for aspiration that we always avoid general anesthesia. But here it is written that duration of surgery was more than anticipated. That means this patient, the duration of spinal would have gone off and patient would have been given general anesthesia. So what impression I can derive? And after that, in post-op, patient developed post-op hyperventilation. Now let's go by choices. Now what all exactly was given in general anesthesia? We don't know. But let's see. Let's go by the choices. High spine anesthesia, not possible. Because high spinal anesthesia, what is first high spinal anesthesia? High spinal anesthesia means the level is above the desired, and that is causing some problem to the patient, and patient problem will depend on the uh, level of the block. Like only say middle intercostals or upper intercostals are blocked, patient will have dyspnea, so oxygenation may be sufficient. Or if the level of block is up to cervical spine, that there occur diaphragmatic paralysis, then patient will have apnea and patient will require immediate intubation. But these complications will occur till the drug get fixed, and maximum to maximum time for the drug to get fixed to the neural tissue is around 15 minutes. Although 90% of the drug get fixed within 5 minutes. So maximum say 10-15 minutes. So this high spinal will occur during first 10-15 minutes, not related to post-op. And secondly, it will not cause hyperventilation. It will actually cause hypoventilation because of the blockage of intercostal muscles. Okay, so this is rule out. Malingering will come again. Hypoxic encephalopathy. Hypoxic encephalopathy again will not be presenting like hyperventilation. So hypoxic encephalopathy means patient will be hypoxic. So actually, again hypoventilated, and so the presentation will be decreased oxygen saturation of the patient. So that also rules out. And cranial nerve palsy, yes, that can occur with spinal anesthesia, and most commonly involved is sixth cranial nerve. But again, it will not present like hyperventilation. It will present very late, like you can say diplopia, photophobia, like that, abducent nerve palsy. So that again is ruled out. So among these choices, we have no option but to choose malignant. And it can happen. Even if patient has not been given GA also, sometimes uh, just as a malignancy can have post-op hyperventilation. And during GO also, yes, blood gas abnormalities can cause hyperventilation, but we don't have that information with us whether CO2 is high or PO2 is less, or some metabolic acidosis or alkalosis leading to hyperventilation. Particularly this acidosis will lead to hyperventilation, but we don't have that information. So with the information available with us, the only option left with us is malignary. So, but again, I like to say that this questions for me seems to be actually incomplete. There is another very important vital information which is missing from this question, or maybe some choices may be different in the exam. So that sometimes this is a problem with recall questions. You really couldn't get exact information, particularly if the question is very long, like this clinical questions. So I think that should be enough. So anyway, with the time, I may get corrected question of this question number one, as well as some more appropriate information for this question number one. When we'll discuss again. And if you have any query, you can directly mail me, Dr. Yadav Ajay at redifmail.com, and then on Telegram group also. I have a group that is Anesthesia Query Group. You can post your query there also. And of course, at our eGurukul, question answer session is there. So there you can post your queries. We try to resolve it as early as possible. Okay then, best of luck. And again, any query, don't hesitate to ask any query. Thank you very much.